So surgery is used to treat cubital tunnel syndrome when, firstly, non-surgical treatments have failed. It is also used as maybe the first line of treatment when patients have permanent neurological symptoms, such as permanent numbness in the fingers or weakness in the muscles of the hand. So this type of surgery is performed formally in an operating theatre. The surgical cut is on the posterior side, on the back of the inside of the elbow here, usually with an incision maybe between 15 to 35 millimeters in length. In terms of the anesthetic, this is often done with general anesthetic where the person is asleep fully, but it can also be done by regional anesthetic where we numb the arm completely. And in some occasions, we also can do it by local anesthetic. Local anesthetic means we would just put an anesthesia to numb only the area around the surgery. This is suitable for either patients who are not fit for a general anesthetic, or it can be for some people who are nervous of a general anesthetic, but there are some limitations with that. So usually general anesthetic, fully asleep, or with regional anesthetic where the arm is completely numb. So during the recovery process, obviously straight after the operation, there will be a bandage on just the elbow, but the elbow is permitted to be moved immediately. The hand is also free, but I normally recommend using the hand only for essential things, no heavy lifting or pushing, but they can start to move and use the hand immediately. The day after surgery, I then recommend them to start to do exercises, which I will show, but it is very simple exercise they can start at home. And the main nuisance for most patients is that the dressing on the elbow has to be kept dry. So they will need a protector they can apply to keep it dry for showering and things. And then normally the dressings and everything are left in place without disturbing until I see them for follow-up about 10 to 14 days afterwards. In terms of pain, for most people, simple domestic analgesia or painkillers like paracetamol, ibuprofen together are sufficient. But in some situations, we can also prescribe some painkillers from the hospital like codeine and so on. The success of cubital tunnel surgery really depends on making an accurate diagnosis. And the accurate diagnosis is achieved by having a good consultation with someone who's a specialist in this area. Sometimes this is supported by further investigations, but the main determining factor in success of surgery is actually firstly making a correct diagnosis, that there are no other causes that might be causing symptoms that are similar to cubital tunnel syndrome. But if the diagnosis is correct, 85 to 86% of patients will go through without problems whatsoever. All surgery, of course, carries some risks. Simple risks like wound infection, less than 1 in 100 cases. The scars can remain tender. The scars are always tender, but in most people settle by 3 to 4 weeks. But in some cases, this scar tenderness can last for many months, but will settle. Other sort of risks of surgery, very small risk of injuring nerves during the surgery. But again, if done by a specialist, the risk is much reduced. And we still say probably about less than 1 in 100 cases. Other risks are that the recovery may not be complete if the condition is very severe before the surgery. So it depends how much damage already pre-existing. But overall, we'd say 85 to 86% of patients will go through very happy with the outcome. So the surgery risks are determined by anesthesia factors. So we mentioned about general anesthetic or regional anesthetic, but these days these are very safe, so the risks are very low of any unexpected problems. Normally a patient will have a preoperative assessment in the hospital where they're going to have the surgery, so all risks are assessed beforehand. In terms of risks of the surgery, risk of complications of the wound infection, scar tenderness, incomplete recovery where they don't make a full recovery because of pre-existing damage to the nerve, stiffness of the elbow, which we minimize by getting to the patient to do exercises from day after surgery, which I will show. But those are the main risks we would talk about. Very rarely, we also can have the nerve subluxes. What we mean by this is where the nerve has been released in the elbow, it can jump in and out of its groove afterwards. This is quite a rare complication. Maybe we see one in about a few hundred patients, so that's uncommon. If that happens, sometimes surgery needs to be done again. Another risk we also talk about with any nerve surgery where we release a compression is a risk of recurrence of symptoms. This can happen in about 5% of people where the condition symptoms can come back again. And this can be for a variety of reasons. If it does, then there are other procedures that can be done, operations, to try and alleviate those symptoms.